On the offset, I would like to thank chairpersons for giving me this opportunity. HDMI. So I'm Dr. Rajiv Gandhi. I'll be speaking on diabetic macular edema, center involving diabetic macular edema.
We have 15 minutes to finish the session, so 4 minutes per talk, please.
Okay.
Yeah, 5-minute discussion.
The amount of VR or the ophthalmologist treating diabetic retinopathy in India is very less. So we have a huge task in front of us to avoid this preventable blindness. So diabetic macular edema, it is the most common cause of moderate vision loss in diabetics. It can present at any stage of diabetic retinopathy. It causes loss of ability to read, write, and loss of independence and loss of employment, affecting the quality of life. Coming to center involving diabetic macular edema. Clinically, it is retinal thickening involving center of the macula, and on OCT, loss of foveal contour, cystic spaces, neurosensory detachment, and retinal thickening involving center of fovea. In CSME, criteria 1, which is thickening at or within 500 microns of the center of fovea, is considered as center involving DME. The other two criteria 2 and 3, are considered as non-center involving. So, while treating, it is important before treating to note down the visual acuity, the best corrected and the uncorrected visual acuity of the patient, the intraocular pressure of the patient, the status of is it phakic or pseudophakic. Investigations like baseline, every diabetic macular edema patient should undergo color fundus, OCT, and fluorescent angiography as a baseline, as these might help to assess for documentation and to assess the response of the treatment. The new modalities which have come into action are OCT angio and ultra-wide field imaging. With the ocular examination, the other thing, very important thing, is the systemic status of the patient. Glycemic control, many studies have shown that tight glycemic control prevents the progression of DR. Similarly, patient with anemia has worsening of diabetic retinopathy. So many lipid-lowering agents like fenofibrate has shown to decrease laser photocoagulation therapy required for diabetic macular edema. The other things, in a patient with diabetic macular edema, you should always check for patient whether the patients are on oral hypoglycemics like glitazions, and if they are on glitazions, you need to stop the glitazions as they enhance the diabetic macular edema due to fluid retention. The other important thing before treating is perfusion status, whether it's ischemic, non-ischemic, whether the vitreomacular interface, there is any VMT or present or absent, whether clinical course, whether it's chronic or non-chronic, whether the distribution of edema is focal or diffuse. The other important thing is to check the disc status to avoid missing overt causes of visual loss. Recently, the patient was referred to me for a treatment of a diabetic macular edema. After baseline investigations, I was unable to correlate the visual acuity with the diabetic macular edema. Then I had re-evaluated the patient, and I found out the patient had AION with diabetic macular edema. So my treatment protocol totally changed. So checking a disc status is very important to avoid any missing causes of visual loss. So these are the different types of DME based on OCT features. So we have treatment options are intravitreal steroids, anti-VEGFs, surgery, and laser photocoagulation. For laser photocoagulation was a mainstay of DME treatment in pre-anti-VEGF area. Today, new modalities like micropulse lasers are used for mild center involving DME. Why are steroids used to treat diabetic macular edema? Because the steroids target the inflammation as well as the VEGFs, as compared to VEGFs, which only target the angiogenesis. The steroids.
Rajiv, you have 30 seconds more.
Yeah, sir. Okay, sir. I'll just conclude this.
I'm sorry, but
So to conclude, during treating a diabetic macular edema, you need to work as a true physician. You need to thoroughly check the systemic as well as the ocular workup. Intravitreal anti-VEGFs and steroids are the mainstay of treatment. Lasers, deferred lasers are used to reduce the number of injections. Anti-VEGFs can be used in phakic patients and glaucomatous eyes. Steroids can be first line of treatment in pseudophakics, vitrectomized eyes, and recent history of stroke or MI. Vitrectomy is a choice of treatment for DME with vitreomacular interface abnormalities and non-responders.